Thank you, Susan, and it's a pleasure. It's something that most of us in gastroenterology deal with, as well as primary care physicians deal with all the time. And I have the title out here as irritable bowel syndrome. However, it's only a part of the disorders of the brain-gut interaction because it's a two-way street between the brain and the gut. These are also part of the functional GI disorders. So if you're Googling stuff, because Dr. Google does know all, you might just want to look at DGBI and SGID as disorders of brain-gut interaction and functional GI disorders when you're looking for irritable bowel syndrome, very distinct from inflammatory bowel disease. So I know we have like an alphabet soup up here, but these are different diseases. Just wanted to do something about today being National Tell a Story Day. And obviously anything that we do in life is we're telling our stories. It's also National Prime Rib Day for those of us that are not vegetarians. It's National Devil Dog Day for those of us that love sweets. And National Babe Ruth Day in case you're into baseball. But more importantly, last week, we celebrated the World IBS Day. So we acknowledged that day, and the Rome Foundation kind of puts out all these patient and physician education resources. It's kind of break the poo taboo. So again, it's something that's important enough that we actually have a World IBS Day acknowledged. Now, what is IBS? It is a prevalent chronic, which means it goes on for a long time, and episodic, which means it's not always as severe. It can have peaks and troughs. And it's about 20% prevalent. So 1 in 5 people may have this. It's higher prevalence in younger women, especially if you've had infectious diarrhea, if you've had a trip over, to say Mexico or to Asia and you've been eating out and you had a very, traumatic diarrheal illness, you can develop IBS-like symptoms that can last for a while. There is a twofold increased risk of IBS if there is adverse events in early life or childhood traumatic experiences. IBS happens in young kids as well as, all the way into geriatric age group. 50% of the patients do not seek health care for their symptoms. So diagnosis can be delayed because the symptoms may not be very severe initially. IBS is associated with a very poor health-related quality of life. A lot of people have reported that they will forego promotions because if it means having to stay up more and interact more, they'd rather just not have that outside activities, especially if they have IBS diarrhea and they really have to seek bathrooms when they're out. Combined direct and indirect costs for IBS management is estimated to exceed over $1 billion annually. So that's kind of interesting. The world prevalence, as you can see, is very high. And in the US, we actually have up to a 20% prevalence, I mentioned earlier. It's also very high in some of the other countries, such as Japan, China, France, UK, and then this one's kind of an outlier. Most of the African countries do not report out on IBS prevalence because, again, there are no mortality. There's not a mortality associated with it. But again, there are some places that have a higher incidence based upon the way that the studies were conducted. Now, what symptoms are we looking at? It's abdominal pain, which is, very ubiquitous. A lot of people have pain in the belly, but that's occasional, once or twice. But if it happens over and over again, and we'll go into criteria associated with discomfort or bloating, and then altered bowel function associated with it, which means you have either diarrhea or constipation.
Excuse me, Dr. Shah, I'm sorry, doctor, to interrupt you just one moment. I don't believe your slides are advancing. So make sure your cursor's on we're still on the first slide. So
sorry, guys.
No, I would put the cursor on your main slide right there. And then just try to hit the advance button. It's the arrow.
Not going to advance. Let's see where it can advance. Okay, stop the share. Excuse me for a second, guys. I'm going to try and do this. Stop share. Let me
Got it.
Can you see this?
So I can see you. We're going to go to share screen again,
Okay.
and then we'll hit your PowerPoint again. Just like you did before.
Can you see this?
I don't see your slides at all now. Okay, something's coming. Okay, great. That's better. Now you're on, but just make sure you can advance by just keeping your cursor. There it
I'm
is.
seeing
We're in
my
now
slide.
Thank you.
Can you see this?
Yep, you're in the first.
Okay.
Mhm.
So, we haven't lost much time. So recapitulating.
Okay,
You
great. Thank
saw
you.
the DGBI, you saw the functional disease. I wanted to make sure that people knew that this was Babe Ruth Day, as well as last week we acknowledged the World IBS Day. So break the poo taboo. IBS, can you see this?
Perfect. It's great. Thank you.
All right, way to go. Let's rock. Just wanted to bring up the prevalence, and about almost half the people that have these symptoms do not seek healthcare because it may not be very severe. And sometimes we talked about break the poo taboo. Most people don't discuss bowel habits over cocktails and do not have embarrassment when they're seeking out physician care for these symptoms. So the diagnosis can be delayed for up to 7 years. We know that it's associated with a very poor health-related quality of life. And I talked about promotions being, bypassed because of this, and the almost $1 billion healthcare cost. This was just a very nice pictorial about how the prevalence is high across the world. And in the US, it's up to 20%. It's higher in certain other areas of the world, but it's worldwide, so no one is immune to this. The symptoms are, we were talking about pain and discomfort. There are also some comorbid conditions, and those are things that occur simultaneously. Fibromyalgia, where are different aches and pains, anxiety, depression, migraines and headaches, chronic fatigue syndrome, TMJ disorders, interstitial cystitis are all associated with IBS. So it's a functional GI disorder which can affect every part from the esophagus, which is the upper part of the GI tract, all the way down. So you can have problems with heartburn, you can have trouble with swallowing, regurgitation, belching, nausea, vomiting, bloating, constipation, and diarrhea, which we're going to talk about as part of IBS, and also abdominal pain, gas spasms, and bloating, which goes along with this diagnosis of IBS. The pathophysiology, it's really a manifestation from interplay of multiple factors. There are genetic factors involved, although we do not know the exact gene that may be involved. They're organic, which is from structural problems with the GI tract. Social issues, psychological issues, as well as diet plays a big role. We talk about brain-gut interaction, and that's why the disorders of the brain gut. There is visceral hypersensitivity, which means when you have increased pain, although there may not be that much of a damage to that organ, or the central processing is abnormal, and that's known as hypervigilance. It is really a bidirectional relationship, and that's why the disorders of the gut and the brain interaction. There is significant impact of life stressors, and when I go to the end of this presentation, I'll point out how that affects the IBS symptoms. There's a role of the GI tract motility as well as altered microbiome. Everyone has their own fingerprint of the gut microbacteria, and these are all different in different individuals. The colon naturally has billions of bacteria, and when those are altered, it also has an impact upon the immune system, and then it causes alterations in permeability and immune activation. And that's what's known as, people refer to it as a leaky gut, which again leads back to this mucosal alterations. The way we diagnose IBS is really a symptom-based criteria. There's a Rome definition, which is recurrent abdominal pain on at least one day of the week for the past 3 months. And the first time you ever experienced this should have been about 6 months ago. And then there's a change in the way of the bowel movement, either with an increase in frequency, or it is change in the form, which means it could be more liquid or it could be more hard stool that you have with us. Now, IBS is just a part of the functional bowel disorder. So it can be IBS constipation predominant, IBS diarrhea, IBS mixed, where you have constipation and diarrhea. You could just have bloating and distension. And sometimes opioids, which are pain medicines, can also lead to functional bowel disorders. We talked about the irritable bowel syndrome. There's also functional constipation. And for this, more than 25% of the time, the stool is lumpy and hard, and people usually feel that they do not evacuate completely. So there's always a sensation of something stuck behind. Some people have to do digital maneuvers to remove the excess stool that they feel is still in the rectum. And then there's fewer than 3 defecations per week. So the frequency as well as the form are both important when we diagnose functional constipation. And diarrhea would be the opposite, where more than 25% of the time there is liquid stool without the use of laxatives. Now, how do we define stool? And this is a Bristol stool scale, which is again on Google, and this just defines different types of stool. If you have what my patients call sheep droppings, rapid droppings, that's type 1, which are hard little lumps like little nuts, versus normal, which is sausage or snake-like, smooth and soft, long stool. And then, I hope nobody's having their late lunch at this point. However, gastroenterologists look at this all the time. So you could be part of us and look at this slide as you have your snack. When you're looking at type 6 and 7, it's what we define as diarrhea, where it's watery and there are no solid pieces. Now, this kind of tells us if there is more of a constipation or diarrhea-like stool, and you can keep a diary of this, because a lot of times when patients say that they have occasionally constipation, occasionally diarrhea, they would fall into the mixed form of IBS. When they don't actually quantify how many times they have it, or they're not able to define it, it becomes unspecified. So this is basically how we define constipation versus diarrhea predominant irritable bowel syndrome. And the reason for doing that is because the way we treat it or manage it will be different. We talked about some of the comorbid problems with this. In addition, patients will have menstrual disorders and sexual dysfunction, as well as eating and sleep disorders. And sometimes they also have avoidant, restrictive food intake disorder, which is a new category that's also in the DSM, which is one of the psychiatry definitions. So a lot of these are coexistent with IBS. When we look at a patient, we really want to know the history. So it's very important for the patient to come prepared with at least some of the problems that affect them, the pain, the bloat, how often they have constipation, how often they have diarrhea. A physical exam usually also includes sometimes if you have constipation with something stuck down in the rectum, a rectal exam at that point. There are certain laboratory tests that we suggest, like a celiac disease serology, something known as a C-reactive protein that tells us if there's inflammation, and stool tests to see if there's infection or parasitic disease, especially if you have diarrhea. You really don't need to have endoscopies done unless you're over the age of 45 and you need to get your screening colonoscopy done. The imaging tests, CAT scans, are not something that we frequently use if we are suspecting IBS. And there are motility tests that can also define if there is anorectal defecation abnormalities, which means it does not coordinate. And that's why you have the sensation of something being stuck in the rectum. There's certain breath tests with glucose or lactulose that can be done, and that's to find out if the patient has bacterial overgrowth in their small intestine. Now, know that in the large intestine, there's always going to be bacteria. That's normal, but you really don't want any bacteria in the small intestine to any great length. So it's really a multidisciplinary evaluation from the gastroenterologist. Often a dietitian is involved, and often a psychologist or psychiatrist. And part of this is to avoid repetitive labs or endoscopy or imaging tests, so that you're trying to get the diagnosis before you get repeated testing. There are alarm symptoms which would indicate further tests, and those are if you had weight loss, if you had an onset of symptoms at older age, if there's family history for cancer or inflammatory bowel disease or celiac disease, or if you're seeing blood in the stool. If there is abnormal rectal exam, that's a digital rectal examination, or there is tenderness when we press on the belly when you come in to see the gastroenterologist, or if we find there's occult blood, which means blood that you don't really see, but when we test it, it turns out positive, in which case we would try and do a colonoscopy or a flexible sigmoidoscopy. On the blood test, if there's anemia or a high white count, or if there's increased signs of inflammation, sometimes the thyroid functions can be abnormal, or if the stool tests are abnormal, we will then want to go ahead and do more testing. I talked about the celiac disease test and the breath test, and then a CAT scan in case we were looking for some mass or a tumor. So the treatment is really focused on individual symptoms, and there are dietary as a first line. There are medications or pharmacologic treatment, and then integrative or complementary treatment options. We talked about abdominal pain and discomfort, as well as bloating and distension as being part of the symptoms of irritable bowel syndrome. And you can give antispasmodics or tricyclic antidepressants, as well as analgesics for these symptoms. You want to stay away from opioid medications because those can further exacerbate the symptoms that you're trying to treat. For the bloating and distension, your doctor might try to get you on a dietary modification of a low FODMAPs diet. We'll talk about that in a minute. And again, give you simethicone, which is like Gas-X, digestive enzymes, or sometimes for small bowel bacterial overgrowth, antibiotics that are not the typical antibiotics for infection. And these are specific antibiotics for the overgrowth of the bacteria in the small intestine. And then for constipation and diarrhea, specifically for each one of these, there are medications. The important thing is none of these medications treat the multiple symptoms of IBS. So just treating the pain doesn't take the constipation or diarrhea away. On the contrary, it may sometimes increase the amount of constipation that you get with this medicine. And the same thing is true with the diet. Sometimes the diet can actually, with increasing fiber, cause more bloating. So you try to finesse out exactly what is needed for each individual patient. I talked about the fiber causing increased bloating, the antispasmodics, the tricyclic antidepressants causing depression. So you really want a multidisciplinary management. I talked about the low FODMAPs diet. The low FODMAPs really means it's foods that are fermentable, oligo, di, and mono carbs, as well as polyols. So what can I eat is the question, right? If I want to try and be on a low FODMAPs diet. These vegetables are okay. You definitely want to try and avoid garlic, onions, cauliflower, broccoli, or mushrooms. They cause increased gas. Now, if you were President Bush and you really loved your broccoli or not, he didn't like it, then eating it once in a while will cause the symptoms, but that does not mean you have to forego it for your entire life. Now, if you exclude these vegetables and then you gradually try introducing one of these at a time, you might find that not all of them cause problems, and you might be able to go back to that broccoli that you really, really want to eat, or the mushroom. Some of these fruits also can cause increased symptoms. But if you're an apple lover and an apple a day keeps the doctor away, you might just want to go back to eating apples, but try and introduce it one at a time. So you try and stay away from all of these for a week, and then gradually introduce the fruit and see if that increases your symptoms. So you do not want to be on a very restrictive diet. You want to avoid that restrictive food diet intake disorder. And then we know that celiac disease is a gluten insensitivity or gluten high sensitivity or gluten intolerance, if you will. So you want to stay away from it. But if you feel you can eat your bread and not have any symptoms, or eat your cake and have it too, by all means, go for it. What are the prescription and over-the-counter medications that you can use if you have constipation? So the first line of treatment is diet, and the next one is over-the-counter medications. Miralax, which is one of the osmotic laxatives, is something that's usually prescribed by your doctors. And then there's Senna, which is my next go-to medicine. The dulcolax or the bisacodyl can cause a lot of cramping. So usually you want to keep it for, very infrequent use. And then Colace, which is like a stool softener, may not really help. So either the Miralax or the Senna is something that I would go to. The prescription medications are the secretagogues or the prokinetics or the NH3 inhibitors. And you've probably heard of Linzess and Trulance and Amitiza, as well as Zelnorm, which is not available as freely, as widely as before. And then this one's kind of the new kid on the block. One of my patients wanted me to prescribe tenapanor, which has also been very recently approved. And most of the data that are out there suggest that the cost versus benefit may be more in favor of the cost, whereas there may be less benefit. So it's not really recommended as first-line treatment at this point. When you look for diarrhea management, there are over-the-counter medications such as Imodium. It used to be a prescription medicine, but now you can get it over the counter. And again, it's a mu opioid receptor agonist. So you do not want to take too much of this because remember, it is kind of has this opioid effect. The non-systemic antibiotic I talked to you about earlier, which was for the bacterial overgrowth, is rifaximin. Again, very difficult to get and get approved by insurance. So you need pre-authorization for this. And then the newer medications for a couple of years now is Viberzi, which is for patients that have a lot of diarrhea. The first medicine that we had was Lotrinex or Allosetron, which again is very restrictive in its use, and there are a lot of black box warnings with it. So you really may not get that medicine. How about antispasmodics? These are again medications that can cause constipation. So if you're IBS constipation, yes, it can take the spasms away, the pain and the discomfort, but sometimes the side effect may be more constipation, and you might have to top off on your Miralax or other medicines. The tricyclic antidepressants, like I said, it is a disorder of the brain-gut interaction, can help both at the central as well as the peripheral level. And the serotonin receptors, there are more of these in the GI tract than there are in the brain. So both the tricyclic antidepressants as well as the SSRIs are not being given to the patient for depression, but they're given to them for the treatment of IBS at times. Again, these are things that we do in collaboration with the psychiatrist or the psychologist so that you have, a multidisciplinary management. I talked about integrative medicine, and that's previously the complementary alternative medicine. And what do I mean by the integrative medicine? You're doing non-pharmacologic or non-medical allopathic medicine. Yoga and meditation, as well as mindfulness, goes a long way. You want to be sure that you think positive, because if you have mindfulness and meditation and you know that your doctors are helping you, you tend to have a better outcome. We know sleep and breathing is very important for life, and yes, even for IBS management. The jury's out on probiotics, whether it helps or doesn't. There's several studies that have been done, but the research is not conclusive as to whether that helps or does not help. Acupuncture will help some patients with constipation, some patients that have pain, and so it's something that can be explored. I tend to stay away from Chinese herbal and homeopathic medications, but holistic care is what one would like to have the patients, being taken care of. Most importantly, it's the patient education and reassurance that's important, that this is a bidirectional physiologic and psychologic as well as biopsychosocial issue. And so all of these things are to be addressed with the patient time that we have. Sometimes you cannot do everything at the same appointment, and then you have several appointments to address these issues. Cognitive behavioral therapy is something that the physical therapist can do, and there are symptom diaries, identifying stress events, and coping strategies that the therapist may encourage. There is psychotherapy and interpersonal therapy that identifies difficulties in relationships, changes perceptions. It's on how you focus on the positive. And then hypnosis, and matter of fact, just this afternoon at noon, there was a conference on hypnosis and how it's been used for over 4 decades in irritable bowel syndrome. It hasn't been used as much in inflammatory bowel disease, but we know that, the mind or the brain conquers all. So their hypnosis, which is not somebody trying to put you under and have you do funny things on the stage. It's mostly the self-hypnosis where you focus on the positive and try to address perception on the pain that you experience. So almost like a mindfulness relaxation. And again, these are strategies that can be taught. There's several things on several apps online that can be accessed, and especially in the last 3 years during COVID, many of the psychotherapeutics were done remotely or virtually. So you can download these apps. Patient-centered management is important. So the doctor-patient communication, which is non-judgmental. If the patient comes and says that they have pain, then the physician has to acknowledge that the patient has a pain. And then the patient, when we're trying to explain the IBS or the FGID or the DBGI diagnosis, it's up to both parties to realize that every test that needed to be done to rule out a structural problem or IBD or other issues has been looked at. The blood tests have been done, and now you're looking at the symptoms. You have to acknowledge the severity and the anxiety that goes along with the symptoms for the patient. The therapists usually discuss coping mechanisms, lifestyle modifications, diet, and then treatment adjustment to meet patient expectations. It's very important to involve the patients in these management decisions because it empowers them, and it's known as shared decision making. So in everything that we do, physicians have gotten away from the paternalistic attitude of I shall say this and you shall do. It's mostly trying to come to a joint decision as to what needs to be done next. And you want to set reasonable goals about when you think you should be getting better or how the severity will be addressed. Because if we don't do that, then the patient doubts the doctor's credibility, diagnostic ability, and they seek further opinions. They get further testing, they get other opinions, and they get more testing, and so on. And it becomes a very vicious cycle. So you want to improve the patient satisfaction and health-related quality of life. You want to create a constructive doctor-patient relationship. Above everything else, you have to reassure the patient that this is what it is. It's either a mind-gut interaction, it is a functional disease. You want to involve the patient in the management decisions, so the shared decision. And you want to make sure that when you're giving the tricyclic antidepressants or the SSRIs, the patient, thinks that they're crazy. But no, it's because of, like I said, the HT4, HT3 receptors in the GI tract, the serotonin receptors that these medications are acting on. And then it's a good question, like, I'm not getting better. What should I change? My symptoms are worse. Is it not IBS? Mayo Clinic did a study on patients for 20 years. They followed them out and they found the symptoms wax and wane. And sometimes you don't have any symptoms for decades, but then it can come back. So it's not something that, is here one day and then it's gone. Although some people may resolve their issues and they do not have, as I said, a brain-gut interaction and they don't have symptoms. For the cancer, we've done the tests, and especially if you're 45 and over, the plug-in for screening colonoscopies. Do check with your doctors. Take the pain away. Well, you can take the pain away in different forms, but you do not want to get addicted to opioids. Will it get worse as I age? And the answer is not really. It doesn't get worse. It comes and it goes. It waxes and it wanes. And then if you're under stress, and keep a diary and see if these are things that are making you get more of your IBS symptoms. So with digital health, you can have better access to care or earlier access, especially in the last 3 years. And as mentioned, apps that you can get on online. And this is what I alluded to when I started this lecture. It was about post-COVID-19 functional GI diseases or, diseases of the gut-brain interaction. Some patients with COVID-19 had GI symptoms as their first manifestations. They had nausea, vomiting, diarrhea, anorexia. Some of them lost taste and smell, and that could be causing the loss of appetite or the anorexia. Now, it is a virus, and so viral illnesses do present like this. So we learned over the year 1 and 2 that even before the fever, the respiratory symptoms came on, patients may have had GI symptoms. the backside of it is that GI symptoms can occur from the adverse events of the medications, as well as the post-traumatic stress and psychological factors. Remember, patients were being quarantined, there was physical distancing, isolation from family and friends. Whether you had the COVID or you did not, you still got distanced. So all of those caused stress. And again, it's a brain-gut interaction. So they increase the symptoms of IBS. We know that post-infectious diarrhea and IBS exist. And I talked about that in the etiology earlier on as the causative factor. And similarly, there is now post-COVID IBS symptoms. They even proposed criteria for this entity. And we have fulfilling Rome criteria for any of these functional diseases in the last 3 months, and onset at least 6 months before the diagnosis, like we said earlier. The previous COVID infection has to be confirmed by a real-time PCR test done in a lab, and this is not a home test, and the symptom development immediately after the COVID-19 symptoms have resolved. And they should not have been functional diseases prior to this, because otherwise we would then attribute the symptoms to their underlying functional or IBS symptoms. So I end with these 2 slides, and kind of goes to what I was talking about earlier about the patient-doctor relationship. You take a medicine, it relieves watery eyes, runny nose, aching head, scratchy throat. The side effects include runny eyes, watery nose, aching throat, scratchy head. And then the doctor says, "Are you try physical therapy, try hypnotherapy." And the patient says, "Are you sure it's not a drug? I've never seen that on TV before." So something to have a conversation with your doctor. And I thank you all for your attention. If you have any questions, I'm happy to take them. Susan, do you want to take over there?
Sure, we do have a few. That was wonderful, Doctor. I especially can appreciate that connection with the gut and brain as a licensed clinical social worker for a long time, and in practice, a huge kind of treatment for people is just helping them to understand what's going on. People get anxious about being anxious, but once you understand what's going on, it's a very different experience for them. So thank you so much. Great information. So somebody, just a few questions. How can digestive enzymes be tested to see if that's contributing to a problem?
Digestive enzymes are really pancreatic enzymes, and I would not go for the digestive enzymes in the herbal stores. Some patients have pancreatic insufficiency. These are patients that have chronic pancreatitis from whatever reason that they have that. One of the major cause of chronic pancreatitis is, alcohol use. And, in the last few years, especially during the pandemic, that was one of the problems. So a lot of patients did have excessive use of it, and that could have caused liver as well as pancreas issues. If you don't have the digestive enzymes, then it's good to replace them with the pancreatic enzymes. However, if you take the enzymes, sometimes they may be detrimental and they can cause side effects. So I would not recommend taking digestive enzymes unless somebody had stool tests done, and there's a way to check for the enzyme in the stool, and it turned out that you did not have enough, in which case you would supplement them and take those enzymes. Does that answer it?
Yes, thank you so much. A question about Imodium, kind of 2-part. How often is too often to take it? And if you do take Imodium a few times a month for the rest of your life, will it affect your health? So how much is too much?
Again, if you have acute diarrhea, which means that you probably got an infectious diarrhea if you went out and ate some food, and I hate to mention this, but if you were having some Chinese food or something and you suddenly got diarrhea 2 hours later, you do not want to take Imodium. At that point, you want to let the infectious run its course, get it all out of your system, drink lots of fluids, take a BRAT diet, bananas, rice, applesauce, and toast, and then continue to drink fluids to supplement it. Some patients have IBS and they have diarrhea intermittently, and that's you running to a meeting and you know that it's going to be stressful and you have IBS with diarrhea predominant, then you would take a little bit of the precaution and take the Imodium before you left home. However, if you have constipation and diarrhea alternating, then that Imodium, even one, may then cause you constipation. So that's something to be aware of. Taking it once every few times, or when you're going out on a trip to South America, Mexico, you might want to take it to prevent your holiday from being ruined if you got sick over there. But again, be very careful. If you think it's going to be infection, you really don't want to take anything to stop it. You want to let it run its course.
Terrific. And just a question about IBS. Appreciate the mental health issues. Have you seen incidences where IBS might be related to trauma from childhood or young adulthood?
Absolutely. There are several studies that were done, and this is both emotional trauma as well as physical trauma and sexual abuse. And there are children of divorced parents that have had ongoing abdominal pain, and there is a pediatric IBS, and they have their own different criteria, Rome criteria. So definitely stress as well as childhood trauma can play a role when they're young, and then that carries through into adult life. So although mental health personnel such as yourself do get that history, sometimes it's difficult for the gastroenterologist who's seeing them, and it's not a specialty practice in IBS, and you do not have a psychologist in your office. I used to have that in my previous life, and you're not doing research. We really don't elicit that information. But if you're seeing a doctor and you think it might be IBS, I think if the patient volunteers that information, it can go a long way in trying to get to that diagnosis.
Thank you so much. Great answer. Also, somebody was asking about the difference between IBS and gastritis.
Okay, so gastritis is really an inflammation of the stomach lining, and it is a different form. If you have dyspepsia, which gastritis can cause, which is feeling bloating, discomfort in the stomach, that can be a functional disease. But gastritis is a diagnosis by pathology. When you had an endoscopy and somebody biopsies it and they see inflammation, that is gastritis. So it's not a diagnosis that we make without having that pathology.
Okay, and just one more question. Is there any research suggesting that IBS could be related to any kind of weather, hot weather time of year? Just somebody's talking about they often get it during the warmer months.
There are no data to suggest that it's weather related, but one of the things that you could look at is I was born in India. I love the warm weather. I have friends that absolutely hate summer, and having lived here for more than 2/3 of my life now, I find that if it does get hot and humid, typical New Jersey weather in August and late August, yeah, I wouldn't be very happy. So if you are brain-gut interaction, and if you're uncomfortable or you have weather-related discomfort of other sorts, it's easy to see why you would get a headache, or on the other hand, get GI issues. So I would say, if somebody wanted to do that as a research project in the community, that would be awesome.
Would be great. Well, we're getting a lot of thank yous. It was wonderful. And really, thank you so much, Doctor. We've really appreciated this time and this great information.